There are a number of different surgeries out there, and most people classify those into restrictive, malabsorptive, or combination. What's a restrictive operation?
Well, a restrictive operation generally means there's no bypassing of the intestine. One of the first truly restrictive operations was considered the vertical banded gastroplasty, the old stomach stapling, where the stomach was just partitioned and an artificial band was put on it. So it truly was restrictive. Patients couldn't eat very much of certain types of foods, and other types of foods they could. And of course, this was very popular 30 years ago and not so popular today. The combination operations typically incorporate some sort of smaller stomach with a bypass going to the intestine. But what we know today is that this old nomenclature, this old way of classifying really doesn't tell us how the operation works. You know, you've been doing this operation for over 10 years, these operations. How do you think they really work?
Well, we're still learning. And you know, part of it is the restrictive nature, which means you're limited on how much you can eat by a small pouch, whether it's the band or the bypass. On the malabsorptive surgeries, at least in theory, you bypass part of the intestine, don't absorb as much. But I think when you look at the combination surgeries, like the Roux-en-Y gastric bypass, it has a small pouch, bypass about a foot of the intestine, out of about 25 to 30 feet of digestion. So only a very small part is bypassed. So is it a true malabsorptive surgery, or is there a malabsorptive component? The malabsorptive component of the gastric bypass is probably very minimal. But what we're learning more about the way these surgeries work, especially with the Roux-en-Y gastric bypass, that small part of bypass really changes the gut hormones. Some of those are the hunger hormones like ghrelin. So a lot of our patients don't feel hungry. They have to remind themselves to eat. Some of those, though, are also some of the other gut hormones that affect things like diabetes and cholesterol. And so it's not just a matter of bypassing part of the intestine or making a little pouch.
So the operations, so what you're saying is the operations don't work like we think plumbing would work, bypassing a certain amount and not absorbing. It's more like brain surgery. It affects satiety centers in the brain through mechanisms we don't understand yet.
Yeah, the theory on the malabsorptive surgeries was you're so efficient with the food that you eat, let's bypass a whole bunch of the intestine. There's not as much contact with the food in the intestine, so you're missing out on calories. But also you ended up missing out on a lot of nutrition when you bypassed a large amount of the intestine. But by doing a very small bypass, it really affects those different hormones. And we know about some of the hunger hormones, and we know that there's different places in the gut where different things are affected. Part of that is the satiety or feeling full. Part of that is the stomach emptying. So there's different factors. And we see some of those in the very first couple inches of the intestine and some of those in the very last few inches of the intestine.
Again, one of the most exciting parts about this specialty is the effect on diabetes and other metabolic problems, even without weight loss. But let's talk about the band. You know, the band is kind of classified as a restrictive operation. The adjustable band that we put in has been around 15 years, but is it truly just restrictive? Is it made to make you throw up and feel bad when you overeat?
The band is considered a restrictive operation, but I think it has a lot of other factors, and some of those are probably some of the gut hormones in the stomach. Some of that's probably the stretch of the little pouch above the band. Some of that hopefully is going to be also along the lines of the psychology and nutrition. So it's a tool that helps. None of these surgeries are the magic pill or the quick fix.
Yeah, I think what's most interesting is as the band has evolved over this period of time, we use it to induce satiety rather than an obstruction or a negative reinforcement.
Yeah, it's not a matter of making the band just so tight that you can't eat, because then in general patients are probably going to lean towards liquid calories, like an ice cream or a milkshake or a juice or something.
And it wouldn't be much fun to eat then, would it?
No, that wouldn't be much fun. And our goal, I think, is to get it tight enough to where the patient can eat a few good bites of good food and feel full.
What about the sleeve gastrectomy? I've heard about this vertical sleeve gastrectomy. Isn't that sort of a restrictive operation? No foreign body, simpler?
Yeah, there's pluses and minuses of each operation. In the sleeve gastrectomy, it's basically a long, narrow tube that empties to the bottom of the stomach, but the rest of that stomach is taken out completely.
You remove the stomach.
Removed completely. So that's a permanent operation. So you do have a smaller tube. You can eat less because you're limited. It's not a big stomach that it's going into. And so there are some aversions to volume. Food choice is not so much an aversion. But by taking out the whole big part of the stomach, completely irreversible, you can never put that back in. Whereas we have to, we look at the band or the bypass, everything is still there, everything can be reversed. Now obviously we don't want to consider any of these operations as reversible, or we don't want our patients to, because we want them to go into an operation thinking that this is my first and last operation, and then they're going to have a much more success.